Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. B. Ravinder Reddy. Sir is MBBS MS, FRCS Edinburgh, FRCS Glasgow, surgical gastroenterologist at Care Hospital, Banjara Hospital, Hyderabad. Sir is also an president of Indian Society of Parenteral and Internal Nutrition. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is nutrition in pancreatic cancer. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you very much for the wonderful introduction, and I'd like to thank you all for enabling me to be part of this Med Talks organized by the IJCP. And today's topic is on nutrition in pancreatic cancer. And as you all know, that one of the scourges or one of the main problems in any cancer is actually the nutrition status, and more so, especially in patients who are unfortunate to develop the pancreatic cancer. I'm trying to go forward, but yeah, okay. So let me talk about cancer in general as such, because there's not much of a difference as far as the pathophysiology and the nutritional modulations and nutritional alterations are concerned in various cancers. Even though the extent of cachexia, extent of malnutrition, extent of muscle wasting may be severe in certain different cancers compared to other ones. For example, if you take squamous cell carcinoma of the skin or basal cell carcinoma of the skin, it doesn't put up much of a nutrition strain on the individual who is actually affected by this, as opposed to a person who has an esophageal cancer or upper aerodigestive cancer. And for that matter, the topic of today's evening is the pancreatic cancer. They are the ones who have very significant perturbations and disturbances in their routine homeostasis. So with that few words, I'd like to, all of you will agree that cancer is increasing the world over. Irrespective of which country we live in, the incidence of cancer is increasing. One of the commonest causes is actually the increasing longevity. Number two is actually the increasing air and other kinds of pollution. Number three is our choices as far as oral nutrition, dietary habits are concerned. Four, the increasing vices in the form of various vices. I'll not go into that, which actually enable the development and pathogenesis of these cancers. And of course, not the least one, but definitely an important one is actually the genetic factor. And we all know that cancer is the leading cause of mortality. In fact, most of the patients with cancer succumb to the disease. And irrespective of which kind of cancer the patient has, nutrition status is very important, because malnutrition is common problem in all the cancers. And at diagnosis, majority of them, or a significant number of them, are actually malnourished. And this is exacerbated more so by various modalities of treatment, be it surgical treatment. Most of the time, it includes a very massive or very debilitating surgery, be it radiotherapy that causes many mucositis, it causes inflammation of all the linings, increasing the energy expenditure, be it pharmaceutical interventions in the form of chemotherapy or immunotherapy, for example, even gemcitabine in cancer of the pancreas. All of them have their deleterious effects on the homeostasis of the metabolism. And malnutrition is the result of many multiple factors in this. One of the main reasons is that there is an altered metabolism and alterations in the homeostasis, disturbances in homeostasis. Compared to all of us, the normal individuals, there is a distorted metabolism. At the same time, there is a need for a very prompt assessment, intervention, and more importantly, monitoring, as to see whether the intervention with which we have inculcated to the patient and intervening, is it optimal or suboptimal, or sometimes even excessive? Sometimes the patient may be optimal at the time of discharge, but when he or she comes for a follow-up, we may need to escalate the nutritional interventions because of the differences in their basic metabolic parameters. Now, I'd like to stress my talk a lot on the altered metabolism and homeostasis. The reason is, even though this topic is on cancer of the pancreas, nutrition in cancer of the pancreas, it is mandatory and of paramount importance that we need to know, we need to become familiar with the metabolism which is grossly altered and resulting in a grossly distorted, disturbed homeostasis. So the metabolic alterations in cancer and their effects can be as follows. We need to know what happens during simple starvation, at the same time, what exactly happens in cancer starvation, because a significant number of the patients are also starving. They may be having anorexia. The anorexia may be due to the disease itself, due to the cancer itself, or it could be due to the surgery, or it could be due to the various medications that accompany surgery, or it could be due to chemotherapy and even radiotherapy as such. So there is a gross difference between simple starvation and cancer starvation. There's a slide or two on the different heterogeneity, like one patient with the cancer of the, let's say, breast, has a different heterogenic metabolism of, let's say, cancer of the bronchus, right? And there is a disturbed the metabolism of carbohydrates, lipids or fats, and proteins. At the same time, the outcome also depends, the nutrition status also depends on the host interactions, that is how our immune system responds and interacts to the presence of this proliferating cells in the form of cancer. And majority of the patients, and especially those with cancer of the pancreas, have cachexia, which can be present from the early on. With that, let's talk about the early phase of simple starvation. Early phase of simple starvation is also called as the starvation in which a person is non-stressed. When I say non-stressed, it could mean stressed as far as physiological stress, or there is no pathological stress as such. So when we don't eat, we eat about 3 meals, and in between we eat a bit of snacks. But when we don't eat, let's say for 5 or 6 or 7 or even 8 hours, then gradually we have adequate amount of dextrose circulating in our body, which is rapidly utilized. And then we have about anywhere between 70 to 100, sometimes even more than 100 grams of glucose in the form of a stored molecule called glycogen in the liver. Glycogen is stored in the liver. There is another aspect of glycogen which is stored in the muscles, but that is not available for the usage. Only the muscle uses it for itself rather than for the systemic usage. So this can last anywhere depending on the storage of the glycogen in the liver. It can last anywhere from 12 hours, 18 hours, sometimes even 24 hours, or even more than a day, unless somebody has got a very severe underlying metabolic stress. So there is an increased amount of glycogenolysis, which actually takes care of almost all aspects of the homeostatic processes which are required. Whereas in the late stage, very soon, what happens is, very soon we exhaust the glycogen present in the liver. And then we have what is called as gluconeogenesis, that is production or formation of glucose from non-glucose molecules. That is, they can be fats in the form of glycerol, they can be amino acids, they can be ketones. There are many, many substrates which act as molecules that enable production of glucose. At the same time, because we are not stressed or in a simple starvation, the extent of insulin secretion is not very high. So the free fatty acids are catabolized so the triglycerides are broken down into free fatty acids and glycerol. And free fatty acids act as a source of metabolism and routine activities. Even right now, I'm talking to you all, the energy which I need is actually provided by the free fatty acids. And in prolonged late phase or in a very late phase, the fatty acid, the ketone bodies are produced, which act as a source of calories. not only to the other organs, but also to the brain. Whereas the red blood cells, which form the maximum number of cells in our body, they need glucose for their metabolism. So in late phase, lipids are the main source, and at the same time, because the person in simple starvation is not under any form of a physiologic or a disease state, the lean body mass is relatively conserved to a significant extent. So in simple starvation, we lose about, let's say, a very minimal amount, about 5 to 8 grams of nitrogen per day, which amounts to about 120 to 200 grams of wet muscle loss, providing about 200 kilocalories per day. And fats provide about 200 grams of adipose tissues are broken down, providing about 1400 calories. These two together are actually sufficient to actually tide over our day-to-day activities. Now, coming to cancer starvation, this is an entirely different ball game because very rapidly the glycogen is exhausted, and there is increased need for the tumor cells of tolerance, especially most of the tumor cells are avid. They love dextrose. That's one of the main bases of which the PET scan is actually developed on. The avidity with which the rapidly dividing cells take up the glucose, which is labeled, and then we look up on the scan. So there is increased amount of gluconeogenesis, and very rapidly the fat is broken down to triglycerides, and glycerol. Glycerol acts as a substrate for fatty acids, as a substrate for gluconeogenesis. But this is not sufficient because there is an element of insulin resistance. So there is more amount of muscle breakdown because in our body, we do not have stores for proteins or amino acids. Each and every molecule of amino acid, each and every aspect of proteins are involved in some function or the other. Unlike the fat, we have stores of fat, we have stores of glucose in the form of glycogen in the liver. We do not have any stores of proteins. So the muscle actually breaks down to provide very amino acids. The two important ones are, number one is glutamine, number two is actually the alanine. They are broken down to provide the gluconeogenesis pathway. At the same time, there's increased fatty acid oxidation. The reason these are broken down is, apart from production of ketone body, is actually the oxidation gives other molecules which are required by the cancer cells to form new cells and newer malignant cells. So in cancer, instead of 5 to 7 grams of nitrogen loss, we lose about a significant amount, 15 to 20 grams per day of nitrogen per loss, which means we lose nearly 500 grams of wet muscle a day. So the muscle reduce the size to emphasize that there is a bit of a muscle loss, a loss of lean body mass. In other words, there is sarcopenia in these individuals, which provides about 400 to 500 kilocalories per day. Yet still, adipose tissue still provides the maximum calories. There's not much of a change. As in simple starvation, even in cancer starvation, it just gives about 200 grams in the form of 1400 kilocalories. So there is an equally, at least in some stages of cancer, there is equal amount of muscle loss as well as fat mass loss in such individuals. And sometimes the fat loss can be more, sometimes the muscle loss can be more, and this continues unabated in presence of inflammation, which produces interleukin, due to increased secretion of interleukin 1, 6. These are the pro-inflammatory cytokines, interleukin 1, 6, and tumor necrosis factor alpha. These three together act on the muscle mass and enable gross loss of lean body mass as well as fat mass. We call it as cachexia. Cachexia is nothing but a loss of muscle mass with or without loss of fat mass, but with an underlying significant inflammation. I'll be talking more about cachexia in my last slide also. So with that introduction, there is a metabolic heterogeneity. Obviously, it depends on the tumor type, right? There can be a simple starvation in some individuals. There can be a metabolic change, and there can be a very significant adaptive change. It depends on one's immune system. And at the same time, it is not the same in all. It may depend on the gender of the individual. It certainly depends on the genotype of the individual. At the same time, it also depends on the other comorbidities and baseline status of the individual. The reason I put this slide is if, let's say, somebody's got an adequate muscle mass and develop the same kind, let's say, cancer of the pancreas stage 2A, and let's say somebody is very cachectic, very malnourished, and develop the same cancer of the pancreas stage 2A. The person who has adequate muscle mass will actually do better, tolerate all the modalities of treatment, and he or she will survive for a longer period of time. So that's one of the reasons why there is a bit of a heterogeneity, and because it depends on the baseline status. And some of them may have increased metabolism. In some, if the interleukin-1 is very high, it reduces the metabolism. Interleukin-1 sometimes acts as a thyroid hormone. It reduces the thyroid levels, and that itself reduces the metabolism. And significantly, some of them may still have a normal metabolism. So we can have increased, reduced, or normal metabolism in all individuals. Now, with that, this is a very important thing, which is the carbohydrate metabolism in cancer. As I already mentioned, there's significant gluconeogenesis. At the same time, there's breakdown of the fats, the lipolysis, the triglycerides breakdown, and it gives fatty acids and glycerol. And these, the new glucogenesis, and this acts as substrate which enters the neoglucogenesis pathway and provides glucose. And increased amounts of glucose is consumed by the tumor as well as the host, especially apart from the cancer cell. The host also uses for the cardiac cells, for the adrenal medulla, for the RBCs, maturity of the immune cells, and the initial phases of the neurons as such. At the same time, most solid tumors rely on the anaerobic metabolism of glucose. This happens irrespective of the presence of oxygen. I'll come to that in the next slide. And because of the absence of oxygen, there is an increase in lactate production because of poor vascularity and enzymatic alteration. And this lactate, pyruvate glucose, it actually goes the reverse way, and this is called as the Foley cycle. This is another way in which it forms glucose. Now, this is not a very cheap pathway. In other words, it's a very energy-dense pathway. To give you an example, the cheapest way to go from point A to point B is actually a bicycle. And one of the most costliest ways to hire an S-Class Mercedes or to travel 1 kilometer, and that is a very costly way to travel point A to point B. And traveling by S-Class Mercedes is actually something like a Foley cycle. Now, let me talk about what happens to glucose metabolism, at least in the early phases, in normal cells, that is, in cells which all of us have, you and me. So glucose, with the help of glucose transporters, enters the cytoplasm of all the cells. The glycolysis occurs within the cytoplasm of the cells. This can occur in the absence of oxygen. It's anaerobic metabolism is converted to pyruvate. And in normal individuals, the pyruvate can actually enter into the mitochondria and enter the citric acid cycle or the tricarboxylic cycle, and also the oxidative phosphorylation. And with the help of oxygen, it actually gives us one molecule of glucose, gives about 38 ATPs. Now, in normal individuals, especially when we are in the gym or running a 100-meter dash or climbing 4 floors, 5 floors without any rest, right? This may not be efficient because we do not have adequate oxygen. That's the reason why we get breathless. In such individuals, we go into anaerobic metabolism. That is, the pyruvate is converted to lactate, and the lactate in turn through the Foley cycle gives us glucose. Now, this is the normal glycolytic pathway. Now, let's see what happens in the cells, especially in anaerobic metabolism and also in cancer cells. It is the same way the glucose enters, where the glucose is converted to pyruvate. But if you look at the arrows here, most of the pyruvate enters the mitochondria. Whereas even if there is adequate oxygen, remember this, even if there's adequate oxygen in the cancer cells, right, very little amount of pyruvate actually enters into the mitochondria to take part in Krebs cycle or oxidative phosphorylation. Most of the pyruvate is converted to lactate. Right? There is not much of a Foley cycle here because very little lactate is converted to pyruvate from glucose. Now, the reason why, and as a process that gives only two ATPs. Now, why does the cancer cell do that? Here, even though there is oxygen, if the cancer cell utilizes oxygen, it can easily get 38 ATP. But the cancer cell is refusing to take the help of oxygen. It is producing only two ATPs. The reason is very significant, and that is because the byproducts of this anaerobic glycolysis, it results in synthesis of various biosynthetic pathways, biosynthetic molecules. The important ones are the ribose, so the ribonucleic acids, the various enzymes, the cofactors for various activities, the fatty acids, the amino acids, the nucleotides. All of these are very, very essential to proliferate. They act as synthetic pathways, they act as biosynthetic molecules for the cancer cell, which is rapidly dividing. So this acts independently on its own, as if it's a parasite. It takes its own decisions to actually get only two ATPs, whilst making all the biosynthetic molecules to enable it to proliferate, so that it can proliferate, it can break the basement membrane here, and then it can metastasize to nearby organs or into distant organs. Sometimes even by a contiguous spread, they invade into that distant organ, just like a pancreatic malignancy encroaches into the duodenum and causes duodenal stenosis. So this is also called as a Warburg effect. This particular thing is called Warburg effect. And Otto Warburg was given a Nobel Prize for actually discovering this particular pathway in our cells. So that's a very important pathway that happens as far as carbohydrate metabolism is concerned in the cancer cells, including the cells of the pancreatic cancer cells. The next one is the fats. There is increased lipolytic factor, that is breakdown of the lipids or fats. There is increased of breakdown resulting in fatty acids and glycerol. And this glycerol is used as a substrate for gluconeogenesis, whereas fatty acids are again synthesized for substrates for cell proliferation by the cancer. So there is depletion of fat stores and an increased metabolism. And this rampantly happens in individuals with pancreatic cancer. This can actually happen very early on, or with the onset of pancreatic cancer. Now, there are also significant changes in the protein metabolism. The changes in the amino acid profiles are, there is a decrease because of rapid utilization. There is a decrease in gluconeogenic amino acids because of rapid utilization. At the same time, some of the tumors, such as tumor of the cancer of the breast, gliomas, malignant gliomas, and 2 or 3 other cancers, they avidly, very, very closely, they need glutamine for their nutrition. At the same time, the other amino acids utilized by tumors are methionine and also the branch chain amino acid called leucine. So all of this results in deficiency of amino acids, which reduce protein synthesis. So somebody who is very healthy at the onset of malignancy will very soon will become ascetic or very, very undernourished or malnourished. So there is the reason why this occurs from here, the patient becomes here, is because of a factor called, just like a lipolytic factor, we also have proteolysis inducing factor, right? And here, most of the major proteins are lost, which mainly comes from the skeletal muscle. And there is an increase in protein breakdown, reduction in protein synthesis. So apparently healthy individuals will actually become just skin and bones, as depicted in this particular picture. So the host interactions of the immune cells are certain tumors actually develop lipolytic factors by, it's not important, but it's called KRAS gene that actually increases the lipolytic factor, resulting in fat breakdown, resulting in free fatty acids, adding a substrate for development of tumor, and this again develops initiates the lipolytic factor, so it goes like a vicious circle and promotes the tumor growth. Oops, sorry. So now, one of the most important things in cancer of the pancreas is a very early onset of cachexia and a very significant extent of cancer cachexia in patients who have cancer of the pancreas. If you want to see how a cachetic individual looks, you can actually, all of y'all can Google Steve Jobs one of the founders of the Apple or the iPhones, and use the search term as Steve Jobs before and after cancer. And you'll see a very healthy, apparently healthy looking Steve Jobs. And by the way, incidentally, he expired, I think, in 2011 or 2012 due to cancer of the pancreas. If you look at the extent of his cachexia, even with cachexia, he was still, presenting various other things. We will not go into that. But this picture will give you an idea of the extent of the cachexia. Now, cachexia can be multifactorial. I'm sorry again. So basically, it activates. Normally, we have naive T cells or unactivated T cells, and they get activated and they produce the interferon, which cause anorexia, cachexia, and onset of early death. At the same time, it activates because the immune cells are activated, especially macrophages. Once activated immune cells, they produce tumor necrosis factor alpha, interleukin-1, interleukin-6, and gamma and interferon. All of these act on the fat depots and fat cells and reduce the lipoprotein lipase, and they disturb the fat metabolism. At the same time, these pro-inflammatory molecules, including gamma interferon, directly act on the skeletal muscle, cause breakdown, resulting in proteolysis, weakness, and depletion and sarcopenia. At the same time, they act on hepatocytes and fibroblasts, and fibroblasts in turn secrete another very potent pro-inflammatory molecule called interleukin-6 in large amounts, and they cause extensive systemic inflammation, increasing the gluconeogenesis, reducing the glucose metabolism, and increasing the production of acute phase proteins. So this is a very intense, energy-intense metabolism. At the same time, it utilizes every aspect of the nutrients in all the stored areas to actually result in cachexia. At the same time, proteolysis in turn can lead to cachexia and also anorexia as such. In some individuals, in the absence of all these, some patients may develop what is called as a paraneoplastic syndrome. And that again, these are utilize the same kind of common pathway to actually develop this. So the effects are there is a significant production of pro-inflammatory cytokines like TNF alpha or interleukin-1, 6, and gamma interferon, and factors secreted by tumor, that is proteolysis inducing factor and the lipid lipolytic factor. All of this increase the resting energy expenditure, reduce the leptin. Generally in pancreatic cancer, in some cancers it may increase. It definitely reduces the ghrelin, which is a hormone that activates, increases the appetite, and definitely increases serotonin, and reduces the lean body mass by reducing protein synthesis, increasing protein breakdown, and increasing utilizing the amino acids stored within the muscles for gluconeogenesis. At the same time, the fat breakdown increases, and the fat production is actually reduced. And cachexia can start even before the diagnosis of cancer. That is, somebody has calculated that cachexia can start when the tumor is just 0.01% of the body weight as such. So there are various assessment of nutrition. We can use any of the parameters. We can use the indirect calorimetry, which is not available very commonly. But the world over, one of the commonest things that is utilized is the patient-generated subjective global assessment. We talk about assessment here. So the assessment, this is one of our, we came up with one of our publications. Actually, this is a global study group. I was fortunate to be, there are two from Asia, myself from India, and I think Takashi from Japan. We represented Asia. We sat together for about 8 or 10 days a few years ago in Rome and came up with this particular global study group of how to recognize and come up with malnutrition. So we need to screen every individual we see. We need to ask him or her, is there a food intake in the last 2 or 3 months? Is there a weight loss, significant weight loss, unintentional weight loss of at least more than 2 kilos or at least more than 1% in the last 2 or 3 months? And is there a risk of malnutrition or illness? If we know the diagnosis that the patient has malignancy, then yes, we already know that. So once the answer is yes to any one of these, then the person needs the patient-generated SGA or physician-generated SGA, and we implement the nutritional interventions such as how much the person needs. This is not fixed. Let's say a patient X, it is not fixed that he'll be getting 22 kilocalories for the rest of his life. On that particular day, it's 22 kilocalories. 3 days, 4 days, 5 days, fine the line, it could be 35 kilocalories. After 40 days, it could just be down to 12 kilocalories. So it depends. So we need to assess them regularly. How much and when? What are the rules? Can the patient eat? If the patient can eat, is he able to swallow? If he's able to swallow, is the secretion of the digestive enzymes intact? If the secretion of digestive enzymes intact, is the digestive process intact? In other words, is there maldigestion? Even if it is digested, is the patient able to absorb? Or we can easily say that whether the patient is absorbing what we give or not by looking at the stool. A well-formed stool means the patient is absorbing very well. So there can be maldigestion, malabsorption, resulting in malnutrition. That's why we need to discuss about assess how and when and what to select the formula. Let's say somebody has got a normal functioning gastrointestinal tract and its function, then he will need just a polymeric formula or a kitchen-based formula. But somebody who's got a significant maldigestion or malabsorption, then we need to give something ready-made to the patient who can absorb it rapidly, and that is a peptide-based diet. So that's why this is very essential. This particular thing is very essential. And then we monitor whatever we are doing, whether it's adequate, we supervene, and discharge nutrition plan at the same time. So that is the assessment. Next, we come to the anthropometric evaluation. We look at the patient's various, height, BMI, or one of the best. Presently, BMI is also important. But what I do in my room is I have a bioelectrical impedance apparatus machine, in-body 770, and we look at the patient's skeletal mass. It tells me that the patient's amount of water, skeletal mass, or even the fat mass. If anthropometric measures are not available, you can use a simple calculations to actually look at the patient's height, waist circumference, and calf circumference. At the same time, we can also look at the patient's muscle strength by doing this simple, hand dynamometer stress, and we can assess that. Then we evaluate, interpret all the biochemical data. Somebody may be having, let's say somebody has low albumin. He may or may not be having malnutrition if it's low albumin. But it certainly means that this patient has a very significant amount of illness. That's what it means. But somebody has got a very low prealbumin. That means he can be malnourished. Similarly, the total leukocyte count. Similarly, the urea. The urea creatinine are very, very low. It tells us that the patient is sarcopenic. So there are various biochemical. We need to become familiar on the interpretation of the biochemical. The assessment of this itself is actually a 1 day's nutrition workshop. So with that, I'll go to the evaluation of skeletal muscle. I've already told you all about the hand dynamometer. If that is not available, we can just shake hands with the patient. Most of the patients will have some element of a CT scan or an MRI. We can use these, put in an extra software and assess the skeletal muscle index. At the same time, we need to be aware that it is not sufficient to give the patient macronutrients in the form of proteins, carbohydrates, fats, micronutrients in the form of vitamins, minerals, trace elements. We also need to give novel substrates such as omega-3 fatty acids. We also need to think of giving mitochondrial nutrients. 9 out of 10 patients with malignancy will have an element of mitochondrial dysfunction. And one of the commonest ways in which we can enable adequate mitochondrial function is actually by giving nutrients. Some of them are alpha-lipoic acid, some of them are coenzyme Q or carnitine. About that, I'll talk about carnitine with that. So with that, we come to the crux of today's topic, which is pancreas. Pancreas, it's probably about a very small organ tucked away behind our stomach, probably about 12 to 15 centimeters, and less than 100 grams. It's a small, ticky-ticky organ, just about 80 grams. But this is one of the most important organs, even though it is 80. Size doesn't matter as far as pancreas is concerned. And it sits in a very niche area in a nice C-shaped part of the duodenum, very closely adherent to the duodenum, sharing a common blood supply, common nerve supply, common lymphatic drainage, common venous drainage, and that's one of the reasons why pancreatic surgery, the learning curve is so very long or so very high. And very important blood vessels are there, and it forms a very important function, which is here. That is both exocrine and endocrine functions, various functions. I'll not go into that. In other words, pancreas, despite it being only 80 grams, plays a very pivotal role in every aspect of not only from birth, but also the growth, homeostasis, immune responses, the non-communicable diseases, various other things. So any derangement of pancreas, it can be deleterious. And this is a picture of probably 2B, I think 3A, I think it is pancreatic cancer 3A. So the overall in survival rate is very poor. And this is from our own Indian statistics. For some reason, even though in the world over, there's a male predominance, in India, at least according to this published paper in 2019 by the Indian Council of Medical Research, we have a slight female preponderance of pancreatic cancers in India. I could vouch for that because from my family, we lost 3 for cancers, and 2 of them were ladies, and one of them had cancer of the pancreas. So this pancreatic cancer is one of the most aggressive cancers. It's a very silent, slow, rapidly spreading, very aggressive cancer. And it has got one of the highest incidences of cachexia. Sometimes cachexia can be present even before the diagnosis. And 1/3 of when cachexia is present, which is in majority, 1/3 of these patients die not due to cancer of the pancreas, but due to the cachexia. And cancer of the pancreas, this tumor will lead to hypercatabolism, breakdown, and systemic inflammation to a very significant extent. You look at their C-reactive proteins, you look at their interleukin-6, or look at the tumor necrosis factor, it'll be quite high or abnormal. There is, at the same time, there's a gross underperformance of the exocrine function, endocrine functions, which increase the incidence of malnutrition. At the same time, the tumor by its mechanical effects or by systemic effects can cause dysphagia. Even though pancreas is not in the throat, it can still cause dysphagia because of its systemic effects. It can cause paresis of the stomach, that is called as gastroparesis. By encroaching into the duodenum, it can cause duodenal narrowing or duodenal stenosis. So much so there is a gastric outlet obstruction. And all the treatment modalities, there are various treatment modalities. The commonest one is surgery. The second commonest one is chemotherapy. Very rarely, sometimes they give radiotherapy, but not very commonly because majority of them are adenocarcinoma. But certainly they give, the other pharmaceutical method is actually by immunotherapy and gemcitabine, which actually has increased the survival rate in these. But all of these modalities have one common effect, and that is the increased energy expenditure significantly. So the challenges in any pancreatic cancer, because it spreads rapidly, are number one, in delayed cases. Mind you, most of our patients we diagnose in a delayed stage. A significant number of them have abdominal pain, and they won't be eating. They'll have loss of appetite, they won't be eating. They'll have early satiety, even about maybe 1 or 2 or 3 spoons, they say I'm full. So that will further aggravate the malnutrition. Constant accompaniment is by nausea. Significant numbers can have vomiting, or it can cause diarrhea, sometimes even constipation. All of these actually increase the nutritional status. At the same time, the pancreatic cancer increases the energy needs. At the same time, it drastically breaks down the protein, that is protein catabolism. Therefore, the malnutrition can be as high as 75 to 80% in these individuals. And once malnutrition sets in, which is a majority of patients with pancreatic cancer, the quality of life drastically reduces, and at the same time, mortality increases drastically. So the options are, number one, oral feeds, the patient can eat. But mind you, in my experience, a significant number of them cannot eat. Even if they can eat, they are not digesting because they have loose motions. Right? So we can give either by oral nutrition supplements or by tube feed. The tubes can be generally, most because the pancreas is somewhere here, it has to be a nasoduodenal or nasojejunal. Even if you do a PEG tube, it has to be a PEG DK. Very rarely we can get away with a nasogastric tube. But if we are doing surgery for some reason or the other, then the surgeon will be, at least I do pancreatic jejunostomy. But nowadays, the medical gastroenterologists are doing endoscopic method or non-invasive method of actually, or minimally invasive method of doing a feeding jejunostomy using an endoscope. At the same time, these patients, significant number of them need supplemental of parenteral nutrition or even total parenteral nutrition. I'll come to that soon. But one of the most significant point from this particular slide is most of them do need oral nutrition supplements. So the recommendations are normally we use about 10 to 14 F tubes. We avoid the silicone coated ones or the silicone tube, and we avoid just the PVC coated tubes. We confirm the position by an X-ray, and this nasogastric tube can be utilized for up to 4 weeks. Anything longer, then the patient will need a jejunostomy or a PETJ. Here we can use about 20 to 24. If it's a PETJ, then we can use about 9 to 12 from this. We start within 4 hours, and this can be utilized for about 1 year. Whereas for jejunostomy, it can be 8 to F to 12 up, very thin. That's why we be mindful not to see that the jejunostomy tube get blocked. We always give continuous, no bolus feed, and we start within 24 hours of the procedure as such. The various aspects of the options for parenteral nutrition are it can be from the peripheral line, or it could be peripherally inserted central venous catheter, or it could be from the external jugular, or it can be intrajugular, or it can be a tunneled one, or it can be a subclavian one. The long-term ones are generally the tunneled ones, so that the incidence of infection is much less. In patients with a complete obstruction, they may need total parenteral nutrition, initially for a short while we prepare the patient for surgery, or sometimes even with the help of chemotherapy, the tumor can shrink, and there will be some element of swallowing and some element of return of digestive function. And at the same time, the patient is fit enough, then we can do a feeding jejunostomy or an endoscopic guided jejunostomy and put the patient on enteral feeds. Most of the patients need peripheral parenteral nutrition, which we call as a supplemental parenteral nutrition. The guidelines are we start at 30 ml, by next day we increase it to 60 or 70 ml. We can go up to 100 ml, but generally the recommendations are hold at 90 to 100 ml because these individuals have significant endocrine deficiency of the pancreas. That's why we need to monitor the metabolic parameters. Number one, it could be grossly malnourished, and if we start very early on with high amounts of parenteral nutrition, they can go into what is called a refeeding syndrome, where we can lose the patient. And that's why we need to give the patient thiamine, and we start slowly on at 30 ml and then gradually increase it to 60 ml. We also give thiamine, we give potassium, we also give insulin. We also give magnesium in these individuals, and also phosphate in these individuals. We need to monitor at least 3 to 4 times glucose. Twice a day, we need to monitor the electrolytes. Once a week, we need to monitor LFTs. Triglycerides to be monitored at least once a week or even at least once in 10 days, because hypertriglyceridemia can occur in patients who are on parenteral nutrition. We need to monitor the mechanical complications. It could be while inserting it could be a pneumothorax or a hemothorax. Sometimes they can be blocked. But most of the patients who have a central line have what is called as a catheter-related bloodstream infection. So we need to monitor very closely on these patients. So the options are, number one, oral diet. But I hasten to add that very few of the patients with pancreatic cancer, we can actually get away with an oral diet. Even in those individuals who are on oral diet, we need to give the patient easily digestible, complex carbohydrates, and a very high protein of at least 1.2 to 1.5 grams of protein per kilogram per day. You can limit to fats to about 0.5 to 0.8 grams per kilogram per body weight, but proteins need to be increased. Now, the carbohydrates can be restricted to not more than 100 to 150 grams per day, and that is the oral diet. At the same time, when we're giving oral diet, we need to think of vitamins, minerals, and trace elements, especially water-soluble and fat-soluble vitamins. We can actually circumvent that problem by giving the patient oral nutrition supplements of medical grade. When I say oral nutrition supplements, for heaven's sake, I do not mean Horlicks or Vomita or Complan or things like that. They are medical grade oral nutrition supplements. They are available many. Most commonly, we can use the polymeric ones. They are they contain the entire whole proteins, whole carbohydrates, whole fats. But in individuals who have a significant amount of maldigestion and malabsorption, we can give this patient peptide-based diet. Peptides are rapidly absorbed. We do not need pancreatic enzymes to actually digest the protein because they are rapidly absorbed by the intestines. Tube feeds can be short term or long term, especially into the intestine. Whereas I suspect that most of the patients will need, at least in my experience, all of them needed supplemental parenteral nutrition to enable a positive clinical outcome. Very rarely we give long-term parenteral nutrition, but there is one patient who is actually on long-term parenteral nutrition after Whipple because he's still not able to tolerate anything for the small intestinal bacterial overload. Anything we give, he's not tolerated. So he's on a long-term parenteral nutrition, even though we are making an attempt to actually inculcate some element of oral diet. Now, one of the most important things in cachexia, and especially in cancer of the pancreas, where cachexia is so very rampant, is actually we have to address the cause of cachexia. I've already defined cachexia as saying that there is loss of muscle mass, there can be loss of fat mass, but the underlying modality is there is a significant element of inflammation. When I say inflammation, think of interleukin 1, interleukin 6, tumor necrosis factor alpha, gamma interferon. All of these, their production can be reduced, their effects can be reduced. At the same time, anti-inflammatory, anti-inflammatory cytokines like interleukin 10, interleukin 13, they can increase, they are increased. At the same time, certain substances called resolvents that resolve the inflammation, protectants that protect from their various immune reactions. All of this can be achieved by giving the patient fish oil to this patient. How much do we give? Fish oil, as we all know, there are two kinds. One is icosa that contains 20 carbon atoms. That's why it's called icosa pentanoic acid. We give over 2 to 6 grams. This has more anti-inflammatory effect. Multiple studies, most commonly about 2.2 grams per day is given. But in some studies, I'm not showing you any studies, I'm just giving you the recommendation. In some studies, they have utilized even 6 grams of EPA, sometimes even with an element of DHA, that is 2-cocohexanoic acid. Both of them are omega-3 fatty acids. By the way, they are not the same as flaxseed oil, they are slightly different. So this is the mainstay in which we can fight cachexia. This is the mainstay. In fact, there's a very nice picture of a cachectic rat before fish oil supplementation. And after 6 weeks, the rat has become more healthier, put on more weight. A very nice one. I have not taken it, but sufficient to say that there is adequate evidence to say that fish oil supplementation will have a positive outcome in patients with pancreatic cancer, especially with cachexia. L-carnitine. Now, this is an amino acid which actually acts normally in all of us. It acts like a shuttle. It acts like a shuttle bus, taking passengers from the airport terminal to the flight and putting them on the flight, right? So that is the carnitine. It's also called as carnitine shuttle. What it does is it takes the long chain fatty acids, which contain about 18 or 20 carbon atoms. Anything about 12 carbon atoms is a long chain fatty acid. They take them and push it into the mitochondria. Now remember, mitochondria has 2 particular layers of cell wall, right? The inner and outer mitochondrial membrane. Very difficult for these long chain fatty acids to transgress through that. So the carnitine actually takes them, as a shuttle and pushes them onto the mitochondria so that they undergo a process called as a beta oxidation, where one molecule gives about more than 100 ATPs. In that way, the person is getting adequate amount of ATPs to actually tolerate the onslaught of the pancreatic cancer. So there are, again, multiple studies to show that carnitine supplementation may help in patients with pancreatic cancer. This is in addition to the standard oral nutrition supplements or standard parenteral nutrition. We should also be thinking fish oil either orally or we can give parenterally, but carnitine generally is given through the oral route. We can go up to 4 grams per day. So once again, there are multiple studies to show that both fish oil in the form of EPA, L-carnitine at 4 grams daily have actually increased the survival rate of these particular patients with cancer of the pancreas. So to summarize, most of our patients with cancer of the pancreas are diagnosed at a very late stage. They can be, one of the reasons is most of them can be asymptomatic at a very early on. Here again, the classic example is again Steve Jobs. Most of molars are cachectic at the time of diagnosis. It's actually the unintentional loss of weight wherein we do investigations and we find that the patient has cancer of the pancreas, especially the body and the tail. If it's there sitting in the head, then jaundice comes in very early on, we diagnose very early on. But in the body and tail, no. Treatment modalities, various treatment modalities, be it surgery, chemotherapy, immunotherapy, emcitabine, all of them increase the nutrition needs of these individuals. And that's why every individual should undergo a prompt assessment, repeated assessment, and one size doesn't fit all. One patient with cancer of the pancreas will need an entirely different set compared to another patient with cancer of the pancreas. And I'd like to re-emphasize that in addition to the standard nutritional interventions, we need to think of supplementing with fish oil and also L-carnitine. And all this is possible, not just in managing cancer of the pancreas, but any malignancy is if we become familiar or if we know the pathophysiology of what is exactly happening in any cancer and especially pancreatic cancer. With that, I would like to recommend these two books, even though there are many books. I'm editor for both. I'm the associate editor for this. This will be available for release from Friday onwards. Textbook of critical care nutrition, and there is a chapter written by a very famous physician from Mexico called Vanessa Fuchs. She's written a time on cancer that includes even pancreatic cancer. And this is the importance of nutrition, published by Carver in Switzerland way back, I think in 2010 we published this. This is available for about $70. There's again cancer of the pancreas, nutrition in cancer. These two have these two particular details of all of these. The other references on my slides, every point I've made, I've given actually a reference. With this, I'd like to thank you all for giving me this opportunity to share my thoughts, and thanks a lot to the IJCP. And I welcome you all to become member of Indian Society of Parenteral Nutrition, and that is the website, ispn.org. Thank you all very much once again. Thank you.
Thank you so much, sir, for your wonderful presentation. We have some questions from our audience, if you'd like to take that up.
Please.
Yeah. So, sir, the first question from our audience is, kindly highlight recent advancement in nutrition intervention for pancreatic cancer patients.
Well, the thing is, I'll come the other way. If you take a patient with cancer of the lung and cancer of the pancreas, there's not much of a difference because both of them are rapidly, they deteriorate, both of them have significant amount of cachexia, both of them have significantly very low 5-year survival rate. If you look at the nutrition status of pancreatic cancer, it's not very different from that of bronchogenic cancer or lung cancer, right? Having said that, in one of my, if you go back to my slides, on my second last slide, there is a meta-analysis, not meta-analysis, but a systemic review of various analyses that actually have taken up these two. So if you want recent advances, in addition to the standard of giving macronutrients, 2 to 4, not more than 5 grams per kilogram per day of carbohydrates, 0.5 grams or 0.6 grams of fats, better to give the long-term fatty acids in the form of omega-3 fatty acids, and at the same time 1 to 1.2 grams of fatty acids. At the same time, ensuring your patient gets the daily requirements of all the water-soluble vitamins and vitamin D. Now we know that 30 is required for vitamin D to maintain skeletal functions, but vitamin D is also required for our immune functions, especially in malignancy. So it's better to maintain the level between 50 and 70 in all your cancer of the pancreas patients, 50 and 70. This came out during COVID and it is being extrapolated even into other malignancies. So there is no specific particular thing saying that this is the new advance in nutrition or this particular nutrient has better. Again, gemcitabine has been shown L-levocarnitine has been shown, and omega-3 fatty acids, multiple studies have been shown. So if you compare, let's say, between 2020 and we are in 2023 November, between 2020 November to 2023 November, there's not much of a difference, not much of a development as far as nutrition of the pancreas is concerned, because there's nothing more. Maybe there are some other elements like coenzyme Q, right, or alpha lipoic acid. These are the things which that needs a multiple randomized control trial. But on paper, if we understand the physiology of how a coenzyme Q works or alpha lipoic acid works, and yes, we may give it to our patients, but are they evidence-based? Not yet. So the only evidence-based ones are standard nutrition therapy. Route you must choose depending on the individualized patients, whether it is oral tube feeds, long-term tube feeds, or short-term or long-term parenteral nutrition. At the same time, giving these two novel amino nutrition made in the form of omega-3 fatty acids and novel substrates in the form of L-carnitine. So, that will generally suffice to ensure that your patient will have adequate quality of life. Remember, nutrition has two things. Number one, it enables the patient to sustain the onslaught of treatment modalities. By itself, it will not increase longevity, but it enables the person to sustain the treatment, the side effects of treatment. Number two, which is very important, is it actually increases the quality of life and independence, which is so very important in all patients with cancer. Thank you. We'll go to the next one if there's any.
Yes, sir. Thank you, sir. So, sir, the next question is, what dietary modification are recommended for patients experiencing pancreatic enzyme insufficiency?
Yeah, the common ones are actually the enzymes which are involved in breakdown of proteins. We need hydrochloric acid to break down proteins. We also need the pancreatic enzymes. Once they're broken down, the pancreatic enzymes enter the second part of duodenum. From then onwards, it takes about 96 hours for the protein to be broken down into its elements, that is, the amino acids. Now, if there is an exocrine function, dysfunction, then these individuals may not be having, or patient may be having a normal exocrine function, but the tumor is sitting at the head of the pancreas, not allowing for the exocrine secretions to come into the second part of the duodenum. And these are the ones who will have some element of maldigestion. Number two is for digestion of fat, we need the lipase. It is called as the pancreatic lipase, which is again secreted, which is an exocrine function of the pancreas. So we need the pancreatic lipase to enter into the second part of the duodenum. So in some individuals, it is not possible, mainly because because the tumor is sitting there, B, the patient has undergone a Whipple's procedure or the surgical resection, or the patient sometimes, very rarely, they'll have some element of a significant dysfunction. In all of them, we need to give a preformed diet in these individuals. And that's why they are called as semi-elemental diet. Semi-elemental diet, it actually contains the proteins in the form of peptides. It does not need any of the pancreatic enzymes or even the gastric acid. Directly, it is absorbed by the intestinal villi, small intestinal villi. At the same time, these peptide-based diets also have fats in the form of medium-chain triglycerides, MCTs. These MCTs are they do not need pancreatic lipase to be absorbed. And mind you that they absorb directly into the enterocytes. From there, they go and enter into the capillaries, into the systemic circulation. Unlike the long-chain fatty acids, which are so long that they cannot enter the capillary, they have to be transported by the lymphatics, by the thoracic duct. Medium-chain triglycerides, or medium-chain fatty acids, right? They are the ones that actually are absorbed directly. They do not need pancreatic lipase. So in patients with significant dysfunction, in other words, we call it as maldigestion, malabsorption, right? In them, we can give semi-elemental diet. In those who have a normal function, there is no point in giving semi-elemental diet. Even a polymeric, that is a complete diet, will actually help. But in these individuals, it's better to give. Now, if these patients, can we do anything in the kitchen? I don't think any kitchen-based diet will help an individual who already has significant malabsorption and maldigestion because of exocrine and endocrine functions. And at the same time, we do not know how much of vitamin C we are giving from kitchen feed because it is destroyed by 10 minutes of cooking. How much of calcium we are giving because even if we give milk products, we boil our milk, 30 minutes of boiling the milk, significant loss of calcium occurs. How much of trace elements we're giving, what is the osmolarity, what is the sterility of these. That's why in these individuals, it's better to stick on to a peptide-based diet or a semi-elemental diet. Now, you may argue saying that they're very costly, my patients can't afford, or I believe in this dictum saying that 1 kilocalorie should not cost more than 1 rupee. Actually, I'll come the other way around because if you give the patient these things, then the patient will come out of his acute aspects, acute illnesses very fast, right? Or at least his or her digestion will come back to normalcy, or at least can be optimized. That's one of the reasons why the patient will spend less amount of time in the hospital, thereby the expenses are actually less. Somebody has done, not somebody, many people have done this prospective studies to show that will a medical grade food be more costly for the patient's ultimate outcome? Actually, it works out to be cheaper because if you look at the kitchen-based diet, you're forgetting the cooking, the person to bring it down, all these things, if you combine all of that, it is as dear or as costly as an oral nutrition supplement. So I am a big fan of a semi-elemental diet in presence of malabsorption, malnutrition. In a patient with normal digestion, I will give kitchen diet. In patient who needs the extra nuts, it's better to give polymeric diet. On.
Thank you, sir. So the last question from our audience is, how does nutritional status impact the tolerance and response to pancreatic cancer therapies?
Actually, if somebody is well nourished, it will enable the person to sustain the onslaught of all modalities, be it surgery, and remind you, majority of the surgical procedures are very intense, very extensive, right? One of the biggest operations in the abdomen is actually for cancer of the pancreas. It's called as the Ripple's procedure, multiple anastomosis. It takes actually, when I was a student doing my master's in surgery, the mortality was about 20%, 18 to 20% following Ripple's. Now it is less than 1 to 2%, right? Because of the recognition that, hey, our patients need to be nutritionally optimized, or very soon the patient will get an element of nutritional support. So not only surgery, but also chemotherapy and other modalities of therapy in the form of chemotherapy, immunotherapy, adjuvant, very rarely adjuvant radiotherapy, they all can enable the patient to come out very quickly, number one. Number two, the quality of life increases drastically. Number three, the side effects of common medications such as antibiotics, right, such as painkillers. Nutritional status actually forms a very important role in enabling the to minimize the side effects of this. Remember, everything will have a side effect. And lastly, if the person's nutrition status is adequate, it tells me as a nutritionally informed surgeon that his gut microbiome is adequate. He or she does not have gut dysbiosis. In other words, they have adequate number of bifidobacterium, adequate number of all the 7 species of lactobacilli, and and various other beneficial bacteria present in the intestines. Now, it is these beneficial bacteria that enable to sustain an outcome, the dictated outcome of a patient, even in cancer of the pancreas. There are a few studies done to show that a dysbiotic gut, disordered gut bacteria will enable the outcome to be much poorer. So, adequate nutrition status is of paramount importance, and it is the duty of every single healthcare professional to see not just cancer of the pancreas patient, but also each and every patient who comes to the hospital, be it outpatient or be it for a follow-up, be it for an inpatient or an emergency. We need to look at the nutrition status of that patient because the denominator of each and every disease, be it communicable or non-communicable disease, The denominator is actually the nutritional status. So we should go the extra mile to see that the patient improves his or her nutritional status. So yeah.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, sir, before concluding today's session, any last remark from you, sir?
Yeah, my suggestion is for all the healthcare professionals and also the medical students and postgraduate students, we need to familiarize ourselves. If we know what happens to the pathophysiology and the metabolic derangements in cancer, we do not need any companies to actually push us to inculcate nutrition interventions. We ourselves will be thinking and we'll be pushing in the nutrition status. And each time the person comes for a follow-up, we are at the same time looking at the disease progression or regression of the patient. We also are looking at the nutrition. So at the same time, we need to be familiar with the various guidelines, how much fat we can give, how much proteins we can give, how much carbohydrates we can give, how much vitamin C we can give. So all of them need a bit of a input. But if you look at any of the textbooks, be it medicine, be it surgery, be it any of the major specialties, within the first 10 to 12 introductory chapters, there is a chapter dedicated entirely to nutrition that shows how important nutrition is. So we need to be nutritionally familiar to enable a positive clinical outcome for each and every patient of ours. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you, sir.